Dear students, now we are going to discuss a bit difficult topic, that is re-entry is a common cause of cardiac arrhythmia. It requires a conceptual learning of this re-entry phenomena. Re-entry is a defect in conduction that permits the wave of excitation to propagate continuously within a closed circuit like this. So this is known as the circus movement. This leads to repetitive activation without the need for any new impulse to be generated. For a re-entry circuit to develop, a region of unidirectional block must exist. Now, re-entry can be divided into two major types. One is the anatomically defined re-entry and the functionally defined re-entry. In case of anatomically defined re-entry, there will be an anatomically defined circuit present through which this circus movement will occur. And either of this, that is anatomical and functional re-entry, they can coexist in many situations. Here in this picture we can see an anatomical block or unidirectional block is present in the ring of tissue, which is going to rise the circus movement. How it is going to rise, we will see in the next slides. A model of normal as well as re-entry phenomena is shown here. If a single Purkinje fiber from two branches, 1 and 2, the action potential will travel down each branch. And if we record it, you will see that it will give a normal recording. Now, if branch 1 and branch 2, they are connected by common connecting pathway, the action potential that travel into branch 3 will cancel each other. So, they will collide here, just like this, they will collide and they will cancel each other. So, there will be no change in the ECG pattern. Now, to re-entry to happen. So what happens? For a re-entry to occur, certain conditions must be met. Number one, there must be one unidirectional block. Here there must be an unidirectional block through which the impulse cannot be passed. Second condition is the premature beat must come, and the timing of this premature beat should be very critical. So the critical timing of premature beat is requirement number 2. And third requirement is the length of effective refractory period of the normal tissue. So here we see in this picture a re-entry circuit with anatomic obstacle of size L formed by the fast and slow conducting limbs. So this anatomical obstacle may be due to ischemia or anything. So surrounding it we have two limbs of conducting pathway. One is the fast limb, another is the slow limb. Under normal conditions, the fast pathway conducts from atria to ventricles, and the slow conducting pathway, it is concealed as the orthodomic wave collides with orthodomic excitation from the fast pathway. So there will be a collision between these two. So in the other pathway there will be no wave front. Now if a premature beat comes and it is very critically timed, so what will happen when this premature beat will come? It will see that the fast pathway, it is still in the refractory period. So there is an unidirectional block here. So that fulfills the first requirement. So when the premature beat it is coming, it will see the fast pathway is in the refractory phase. So what it will do? It will propagate down the slow pathway. And when the impulse comes to this juncture, it will try to again move through this obstacle which was initially at the refractory stage. Now when it will come after moving through the other side, when it will come to this juncture and sees the original spot, it is now in the advanced state of recovery. So its refractory period, it is not absolute now. So it will re-excite it, and this will set up and recurrent activation adjacent to the myocardium, and there will be a spinning circuit that goes round and round enclosed in the AV node, and that allows for the rapid stimulation of the ventricle. Step 1 is an initial impulse typically discharged by an ectopic focus reaches the atrioventricular node. There are two pathways in this AV node. One is refractory and the other is not. The impulse is blocked in the refractory pathway, but it is conducted through the excitable pathway. Ventricles are depolarized normally through this His-Purkinje network. The impulse is conducted back through the previously refractory period, which has now become excitable. The impulse circulates back through the atrioventricular nodes and establishes a re-entry circuit. The impulse will spread through the atria and activate them. The chances of developing re-entry circuit is more if the path length is long enough or the conduction velocity is slow enough. That we know that here there is a refractory path and the impulse is moving through the slow pathway. If this pathway is long enough or the conduction velocity is very slow, so it will give sufficient time to this area so that it can be recovered from its refractory condition, and the wave will move in the retrograde direction and will create a circus phenomena. Now in this hypothetical example, here we can say that wavelength is WL. It is equal to the product of conduction velocity into the refractory period. It is much shorter than the path length. So wavelength should be much shorter than the path length so that it can get the sufficient time to be recovered. Now an excitable region, we can see here an excitable region or excitable gap will separate the front of the impulse from its refractory tail. So this gap is known as the excitable gap. This excitable gap actually refers to the excitable myocardium that exists between the head of the re-entered waveform. So this is a re-entered waveform, its head, and tail of the preceding waveform. This gap actually allows the re-entered wave front to continue propagation around the circuit. Can this re-entry be abolished? This re-entry can be abolished, one, by the marked slowing of conduction, converting the unidirectional block into bidirectional block. So here it was the unidirectional block. So when it was recovered, the wave is coming and again passing through this pathway. If we can make this conduction, this slowing of conduction in this area, so these unidirectional block will become bidirectional. So the retrograde wavefront will not be able to penetrate this area. Okay, so this is one way, that is marked slowing of conduction and converting the unidirectional block to bidirectional. It can abolish the re-entry. Another is the acceleration of impulse, that is a retrograde impulse, so that it reaches so early to meet the refractory tissue. So this, we can accelerate the impulse in this slow conducting pathway so that when it will reach this area, it is still not recovered from the refractory period. So by these two methods we can abolish re-entry, and for this we can use certain drugs. How can we make the conduction very slow? So this can be caused by the partial depolarization of the membrane. So here we can see here this sharp rise, that is the slope of phase 0, that is depolarization, if it is depressed. Okay, so there will be, so that if the depressed first channel response can be obtained, then we can slow the conduction. Now cells tending over from fast channel to slow channel depolarization, which conducts extremely slow. So when a fiber is depolarized to a resting membrane potential of say minus 60 millivolt, the sodium fast channels are inactivated, but it can still develop calcium or slow channel response. So one way is by using these sodium channel blockers, we can slow down the slope of this fast depolarizing phase, and we can reduce the uh, conduction velocity of the impulse, and this can help to abolish the reentry. So we can say that circus movement, it is a common cause of different arrhythmias. So once this circuit is established, it can cause many arrhythmias like paroxysmal tachycardia in the atria, ventricles or nodal tissues, atrial flutter and atrial fibrillation. So it can explain that re-entry phenomena can cause cardiac arrhythmias. Thank you and subscribe. Please give suggestion for our next videos in the chat box.